Welcome, I'm Carol Caprio, and you are listening to a New Life Counseling podcast. The goal of this podcast is to share some of my insights that could help both counselors and clients. The topic for today is the vagus nerve and the polyvagal theory, and how trauma affects the body, along with how to integrate the polyvagal theory with EMDR. We all know that the body's nervous system is very complex. Here is a simple diagram of the parts. We're going to focus on the autonomic nervous system, which is a subset of the peripheral nervous system. The autonomic nervous system is automatic. As the name implies, it always responds automatically. It is intended to keep us safe, no matter the threat. Originally, it was from the tiger. More recently, it helps when you are on the highway and the tractor trailer beside you attempts to change lanes. You need to react immediately. You don't have time to think. You just need to react. But it also helps the body return to normal when it should. It's divided into three parts: the sympathetic nervous system and the parasympathetic nervous system ventral and the parasympathetic nervous system dorsal. This is the basis for the polyvagal theory. The polyvagal theory was developed by Stephen Porges based on decades of research. He started studying heart rate variability and found it was based on the vagus nerve. Deb Dana then brought this to the clinical setting. The polyvagal theory describes the adaptive function of the autonomic nervous system as is mediated by the vagus nerve. According to Stephen Porges, one of the key tenets of the polyvagal theory is that our autonomic state is effectively the lens through which we perceive and experience the world. Basically, our perception is our reality. So let's start with an overview of the vagus nerve. The vagus nerve is the 10th cranial nerve, the longest of the 12 cranial nerves. It mediates responses of the parasympathetic and sympathetic nervous system and acts as a cardiac pacemaker influencing heart rate. It is the neurological mechanism underlying the experience of feeling safe and plays a critical role in responding to fear and danger. It connects to every organ in our body. When we perceive threat or danger, the nerve activates the physiological responses of either hyper or hypoarousal. Hyperarousal responses are the physiological effects of the sympathetic nervous system, while hypoarousal are the physiological effects of the dorsal vagus nerve, and this is commonly known as the freeze function. Now we're going to spend some more time on the three circuits of the autonomic nervous system. The sympathetic nervous system is responsible for mobilizing responses and behaviors. Its activation increases the heart rate, the blood pressure, respiration, and perspiration. It inhibits the bladder from voiding and slows down the intestines and represses salivation. This circuit is where anxiety, panic, rage, hypervigilance, rumination, physical irritability, and nightmares fall. Activation of this circuit is in response to danger, which mobilizes the fight or flight response. The parasympathetic nervous system is what is referred to as the vagus nerve. It immobilizes and slows down our body and is considered our relaxed and ready nerve. It is divided into two sides: ventral vagal nerve and dorsal vagal nerve. The dorsal vagus, the back side of the nerve, is the most primitive and what drives hypoarousal. When the body senses danger, it causes immobilization, increasing energy conservation, and prepares for potential death or severe harm. The heart rate and breathing slow down, decreases oxygen to the brain, impairing cognitive function. The face loses muscle tone. A few of the symptoms include dissociation, depression, depersonalization, and derealization. It also diminishes the ability to learn. A trauma survivor can get stuck in dorsal vagal since they never feel safe. The ventral vagal, the front side, is the most recent circuit of the three. It allows mammals to socially bond and cooperate. It's considered the just right zone where homeostasis, health, and wellness exist. Our bodies function as they should. Now let's talk about neuro-informed counseling. A neuro-informed approach shifts our critical focus away from the pathologizing the dysfunction towards curiosity for the function of the dysfunction. The client's clinical complaints and symptoms are important clues provided by the nervous system that guides us to the root of the problem. Neuro-informed counseling recognizes that dysfunction Dysregulation in the nervous system leads to common clinical complaints like depression, anxiety, addiction, suicidality, personality disorders, and psychosis. The brain's neuroplasticity provides us the ability to heal and transform. The innate drive towards homeostasis and wholeness is the core principle of psychotherapy and any healing profession. Our biology is geared to work in our favor, and our hardwired survival responses are protective. Problems can arise when our biology gets hijacked, when we get stuck in chronic states of survival. Long-term activation of defensive autonomic states wreaks havoc on the mind and the body. When we accept and honor that it's all biology, we can easily be curious about the function and the significance of clinical complaints. We recognize behaviors as attempts to compensate and soothe. Clinical complaints and symptoms can be accepted as a unique language. The nervous system is speaking, pointing out areas needing intervention. The symptoms are the data points. Now let's look at the window of tolerance. What does it look like to be within our window of tolerance, being safe and connected, being in the parasympathetic ventral vagal state? Our psychological responses are: we are in the present moment, calm and regulated, we can manage stress effectively, regulate our emotions, things just feel right. We're able to be curious and engaged and connect with others. Now, physiologically, our digestive and immune systems are functioning. We are engaging in eye contact. Our heart rate and blood pressure is regulated. Our blood is circulating to non-vital organs, and our breathing is normal. So next would be hyperarousal. We're mobilized into fight or flight. The sympathetic nervous system is in charge. Our psychological response would be: we have an increase in energy, we have an urge to fight or flee, we feel overwhelmed, we have anger and rage, we feel anxious, we have a busy mind, obsessive thinking, distracted, difficulty concentrating, and we have diminished ability to connect and re-engage with others. So physiologically, we have increased heart rate and blood pressure, our adrenaline is pumping, we have increased flow of oxygen and blood to the vital organs and decreased blood flow to the non-vital organs. We have increased capacity for blood clotting with decrease in digestion and production of saliva. We have a depressed immune system along with increased breathing, restlessness, and muscle tension. And then we have hypoarousal, immobile and collapse. It's the parasympathetic dorsal vagus nerve. Physiologically, we lose energy, we are disoriented, our mind is blank, we experience derealization or depersonalization, we're depressed and numb, we lose interest in activities, we feel isolated and disconnected, we feel helpless, hopeless, despair, we lose orientation, we have flat emotion, we have diminished capacity to engage with others. Our physiological responses include feeling immobilized and preparing for death, we have increased pain-reducing endorphins, we feel numb and fatigued, we have depressed heart rate, blood pressure, and slow breathing. We have depressed immune responses. We have diminished eye contact with others. We have diminished muscle tone and facial expressions. And we have increase in our fuel storage. One thing that doesn't get talked about very much is chronic dorsal vagal shutdown. The dorsal vagal is the source of survival for the short term, but some trauma victims can get stuck there indefinitely. Normal shutdown evolved to be a state that we enter into and come out of in brief periods of time. Unfortunately, highly traumatized individuals can enter shutdown and remain in shutdown, which is sometimes called a functional freeze. So how do we recover from a dorsal vagal shutdown? Coming out of chronic dorsal vagal shutdown is not quick. The client needs to slowly emerge from the shutdown. If done too quickly, our sympathetic fight-flight energy will enter our system as we do so. The return of sympathetic energy can be overwhelming for people, which stops the process and sends them back into shutdown. We need to increase the cues of safety that our system recognizes. They are cues that provide the ability for our body to be calm. Everything around you right now is affecting your polyvagal state. Pieces of the environment, such as lighting, sound, smell, proximity, these are all areas that can be leveraged to help the client feel safe. So some books out there claim that you can only be in one state at a time. This is actually misleading. When you're relaxing, petting your dog, or just finished meditation, you are quiet, peaceful, still, and safe. Therefore, you're in both ventral and dorsal. Here are some other combinations you could run into. When you're in what should be your normal state, you are in what is called social communication. Green, which says that your ventral vagal system is in charge and you are feeling social. When you're in the mood to play or dance, you're in both green and yellow, which is ventral and sympathetic. When you're in fight or flight, yellow, you're in the sympathetic and ready to mobilize. When you're ready for intimacy, you're in ventral and sympathetic, green and red. The next two are combined by a lot of sources. Stephen Porges does not separate them out. When you're trying to appease someone, you're in ventral, dorsal, and sympathetic, which is green, yellow, and red. An example of this is when the victim is attempting to convince the perpetrator's nervous system that the victim is actually on their side. When you're fawning, yellow and red, you're trying to please the perpetrator through compliance with an expectation that they will be less aggressive and less violent. When you shut down or dissociated, you are in dorsal or freeze, red, totally immobilized. Neuroception. The principle of neuroception is that our nervous system is automatically scanning the environment for cues of danger below our awareness. It listens from the inside of our body, outside in our environment, and between the interactions of two people. Neuroception determines what state we are in depending on our environment. So basically, it slowly scans the three environments without our conscious awareness, scans each of the three environments for cues of safety or danger or discomfort, and makes any changes that it feels appropriate. So with exteroception, light, images, color, smells, sounds, textures, and temperatures. Within, interoception, hunger, thirst, energy, and pain. And the in-between is the body language, the eye contact, the appearance, clothing, expressions, and vocal tones. As I just mentioned, neuroception is always scanning and appraising. As the autonomic circuits are activated in response to its analysis, we should consider neuroception to be the body's internal home surveillance system. Its job is to respond quickly to danger. It's a passive process, but we can make it active by intentionally scanning for clues. Now, the vagal brake, which is a physical mechanism of the vagus nerve that reduces sympathetic arousal by dampening the heart rate. Without the vagal brake, the heart would beat at 120 beats a minute. When the brake is applied, it produces a de-arousal effect of the nervous system. When the brake is removed, it produces an arousal effect on the nervous system. A flexible vagal brake contributes to well-being. Next, the vagal tone. It's a term that describes how flexible the vagus nerve is at mediating the autonomic responses. It's based on the functioning of the vagal brake. Supports the need to increase or decrease energy throughout the day to meet our life's needs. A high vagal tone is associated with health and wellness. A low vagal tone is associated with dis-ease, pathology, and distress. Vagal tone is established by attachment and co-regulation. Play and co-regulation serve as learning tools to engage and disengage the vagal brake. The vagal tone is built through skills that calm and relax the autonomic nervous system and move us in and out of an adaptive response. Some examples would be yoga, breathing, mindfulness, comfort, nurturing, safety, nourishment, sleep, to name a few. There's lots of ways to manage the vagus nerve. Make sure you have your list. Every body is different. So now we'll talk about the social engagement system. We need to feel safe to have healthy bonds. We need to feel safe to produce oxytocin. Oxytocin promotes bonding and the neurophysiological development. Safety is a prerequisite for social bonds and learning to develop interpersonal skills. When defensive circuits are recruited in response to fear, our capacity to connect and bond diminishes. In sympathetic, we're more likely to misread others as hostile, aggressive, or angry. In dorsal, we struggle to make eye contact and have energy in our relationships. In sympathetic and dorsal, we move away from connection and toward the defensive protection. One of the contributions from Deb Dana is the 3 C's, cues that the autonomic nervous system is constantly scanning. So, context offers information and education about the who, what, where, when, and why of the work, and it outlines expectations and boundaries. Choice empowers the client. Without choice, there's a risk of exploitation and out of balance power dynamics. And then connection, safe connection to the therapist. The healing antidote to trauma is safety and connection. So why do we connect polyvagal and EMDR? EMDR is focused on the storage of memory. Memories evoke autonomic responses. The autonomic nervous system is also involved in the storage of memories. Without polyvagal theory, EMDR is missing a significant portion of the neurobiological process. So the 8 phases of EMDR are still included with polyvagal, but as you can see, safety has been added to phase 1. History is limited to what the client can handle. These cases tend to be a lot more complex. You'll need to spend a lot more time on phase 2 in preparation as well. So phase 1. First, you must establish a sense of safety. Then you can progress with case conceptualization. Without safety, flowback or bridgeback techniques can trigger the client. During this process, you should assess the autonomic function. Do they have an overactive sympathetic circuit? Are they stuck in dorsal vagal? Can they handle dual awareness? And really doing a neuro-informed history taking is a process rather than a task. Check for dissociation. Is it dorsal, structural? Check for addictions, eating disorders, self-harm, etc. So phase 2, we're going to determine their window of tolerance. They have to be safe enough to feel. If the client doesn't feel safe in their life, you have to determine what the nervous system can handle. What is the difference between feeling unsafe and being safe? I feel unsafe, but I recognize that's not accurate. I feel unsafe and I'm not safe. Or ask the client, does it feel like you have enough safety in your life to do this work? Some clients challenged by chronic pain may neurocept feelings and sensations to be cues of danger. They may be very protective of their body, understandably so. Clients must also feel safe with their therapist. So next is being able to notice and name. The client learns to observe, notice, and explicitly describe internal experiences, which is known as neuroception. It is developed by inhibiting defense responses when not needed with co-regulation. It's increasing safety, moving slowly, and experiential learning. What is needed? Neuroception, mapping circuits, and developing vocabulary. Next, the flex and feel. This requires some tolerance and patience. They need to learn to be with feelings versus numbing and avoiding them. What is the client's relationship to feelings? What message did they receive from their family about feelings? What are their cultural factors? What is their neurodiversity? You need to use appropriate skills to maneuver autonomic states flexibility. This may require inhibiting defense responses. You may consider using EMD, EMD bombs, SIPOs, flash. There's other very effective tools as well. Next, all this comes together with trusting the process. The outcome of mastering the first 3 skills of the preparation hierarchy, the byproduct of vagal flexibility, learning to feel safe when you are safe, and a shift of neuroception, feelings, sensations, memories, therapy, healing, are not all cues of danger. Trust the process, require that you must trust your neurobiology. So phase 3 through 8 are basically the same with a continued focus on safety. So integrating the polyvagal theory with your specialty. Polyvagal theory and EMDR are already integrated. Be sure to bring both into your session, assuming you're EMDR trained. Make sure you're neuro-informed. Focus on treating the nervous system. It is all about biology. And it's not just EMDR that can be integrated with neuroscience. Neuroscience can also be integrated with somatic experience, cognitive behavior therapy, internal family systems, just to name a few. So we talked about using EMDR and polyvagal together, but also there's some devices that I've had good results with, such as the Apollo Neuro, clients that really like that. There's other recommendations using the Sensate or the TENS unit and attaching it to your ear. There's also the polyvagal exercises, breathing, humming, singing, chanting, gargling, massage therapy, stretching, yoga, cold shower. So it's really figuring out what works best for your client. So I wanted to include the sources that I used. I think they're excellent books, starting with Polyvagal Informed EMDR, A Neuro-Informed Approach to Healing by Rebecca Case. Our Vagal World, written by Stephen Porges and his son Seth, which makes it much more readable to the average person, and Nurturing Resilience by Kane and Terrell. Thank you for listening today. I hope you found this information beneficial. Please check out my website, newlifecounselingpodcast.com, to listen to additional podcasts. Please email me with any questions, comments, or additional topics at carol@newlifecounselingdfw.com.